Thank you very much, Beth. I appreciate it so much. And to Dr. and Dr. Hauser, thank you for your words. I appreciate it. I can't say enough about all the support that people have given mental health. I'm sorry it's resulted in a tragedy like this. Unfortunately, these things happen, and that's why we're here today, is we're to help people get the help they need when they need it early in the process. So if you bring up the first slide, please. Okay. So what I'd like to do is talk about the 6 areas that Dr. Berkey had as a goal for this summit. I'm going to talk about the first 5 in varying degrees, and then as we conclude, we'll look at the next steps, and hopefully we have concrete steps that produce concrete results as we go forward. I'd like to start off with talking about the World Health Organization's definition of mental wellness. And it talks about, to emphasize the major points here, a state of well-being in which the individual realizes his or her own abilities and can cope with normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. I think that's a great definition with one exception. It says a state of well-being, and I really don't think it's a state of well-being. It's a process. It's an ever-evolving process that takes work, just like physical conditioning. It takes work continuously, and you can't have a simple static state. So that's what we're here today to do, is to work on that. The Centers for Disease Control talks about mental illness, which is one aspect of mental wellness. It's one end of a spectrum on that continuum. But it talks about sustained abnormal alterations in thinking and mood or behavior associated with distress and impaired functioning. And that is a safety issue for us as well. And that's why it's so important in aviation. It's important for everyone, but particularly in aviation. So to look at the stigma of disease, or what people perceive as the stigma of disease, it really is a very common condition. 25% of Americans will have a mental illness at any one time during the year. That's more than have cancer, that's more than have diabetes, that's more than have heart disease. This is a common condition. It's a disease. And in our lifetime, 50% of us will have some sort of mental illness during that period of time, albeit in most cases a very transient situation. Now, people with mental illness have a substantially increased risk for either unintentional or intentional injury to themselves. And there's a strong association with alcohol and tobacco use. As Dr. Berkey mentioned, we do the HIMSS program, and we see a lot of coexisting disease, anxiety, and depression associated with alcohol use. And it's also associated with many chronic conditions. Think about the individual with chronic back pain, or someone who is caring for an impaired child of some way, and it's a chronic condition. They are faced with this on a regular basis. But the good news is that most mental illnesses, particularly if intervened early, can be managed very successfully. I showed this from the World Health Organization slide about the prevalence of, in this case, this is disability-adjusted life years by group, and this is worldwide. But if you look at this, you see the age cohort that we're talking about, the 19 to 30-year-old cohort, depression, substance abuse, alcohol, anxiety is most prevalent in this group, and it fades later. But the individuals that we're trying to work with today are those people at most risk for these conditions. And we see suicide rates over the last 20 years increasing significantly throughout the United States. And these are factors. And look at the top part of the slide here. When you look at, when you consider the people that we have the privilege of working with, right? The young children, young adults who are out there trying to fly. Relationship problems. Substance use in college. Crisis coming up, a test, a check ride, etc. Physical health problems. They're at increased risk for all of these conditions just because of their age. And even the best of us can have these conditions. We're all very familiar with what Simone Biles went through during the Olympics when she had great expectations on her. She's clearly the best in the world. And then Michael Phelps has long time been a strong advocate for mental health. And I think what he says in this slide is particularly important, that asking for help is not a sign of weakness. And if someone wants to call him weak for asking for help, that's their problem, because he's protecting his own life. And he's become a very vocal advocate for mental health. And he talks about that this is going to affect all of us. We're all going to face grief. We're all going to face loss. We may or may not face some of the other conditions that may trigger these feelings of reduced mental wellness, but we're all going to face this, and we need support when we do. So what are the barriers to pilots seeking help? Well, the big one that Steve Dixon addressed, that everyone here is going to talk about, is a loss of medical certification from the Civil Aviation Authority. I've just listed 3 that are up there. It's a problem across every pilot who holds a medical certificate. He or she fears a loss of their career, a loss of their opportunity to fly, be it temporary or permanent, because of reporting and seeking help for mental health problems. But I'm here to say that that's not the case. And as you heard Captain Dixon talk about, only 0.1% of FAA medical applications get a final denial. But let's talk a little bit about this. This has received international attention, and these are publications that really have come out, with the exception of the FAA ones at the bottom, come out in the last 5 years since Germanwings. And I want to put in a pitch for the Fitness to Fly, a medical guide for pilots. 3 of the 8 chapters deal directly with mental health issues, one specifically and others with substance use and fatigue. And this is a page from chapter 2 of that book, and it talks about mental wellness and all the things that we can be doing right now. This is that work that we do, that daily exercise for our mental wellness that we need to do to stay on that one end of the spectrum of mental wellness where we function most efficiently. So what is the FAA's philosophy about that? And I feel a little bit intimidated because I have Dr. Giovanetti back there talking and Dr. Flynn following me, but I think I can speak for her. I did serve on the Pilot Fitness Aviation Rulemaking Committee following Germanwings, and these were some of the conclusions that we reached as part of this, is that all of us, just because we're pilots, doesn't mean we're Superman or Superwoman. That medical certificate doesn't give us an exemption from any disease that the rest of the population is facing. And we're going to have those mental health stressors in our lifetime, and those are a threat to safety. Okay? And we recognize that barriers exist, be they perceived or real. We also concluded that peer support networks are essential to assisting with this, because the peers are the ones most able to give support. I was fortunate enough to be in fighter squadrons in the Air Force, and there was that camaraderie, that peer support that really wasn't through any training, but it was just people sitting together, flying together, being in the hangar together, being in the ops room, being in the O Club, where we got support from each other, and it was wonderful. The good news is that most mental health conditions are safely treatable. I'll talk about a few that perhaps aren't. And when they're stable or resolved, it's perfectly safe to go back to fly. And in fact, the person may be better off flying in that situation than the person who is struggling and hasn't reported that. But there are a few conditions that are unstable, and they're not really safe to fly, either at the present or in some cases forever, but they are exceedingly, exceedingly rare. And we also know that psychoactive medications may affect cognition, so that's one consideration we'll talk about. So just briefly looking at Part 67, it only lists 15 disqualifying conditions, although the Guide to Aviation Medical Examiners lists much more, but this is directly from Part 67 about disqualifying mental health conditions. And so I list those there, and we'll talk about substance dependence in a second because it is so common. It talks about substance abuse within the last 2 years, but it also talks about personality disorders. But the bottom line is that the concern of the FAA, very appropriately, is that the individual may not be able to exercise the abilities of, exercise the responsibilities of their duties safely during that period of time that they have that, or for the time that they're certified to fly. And these are the conditions that are generally permanently disqualifying and not waiverable. And those are psychoses, personality disorders manifest by repeat overt acts, and bipolar disorder. And that's because these conditions recur. They're very unpredictable about how they do that. There's a paradox of the medications. You think about the bipolar individual who starts taking his or her medication, and they start feeling much, much better. And then they stop taking the medication, and then they have a recurrence of that. So that's problematic. And the behavior associated with these three conditions really is potentially risky to the individual or to others that are around them. And the person has very little insight as to their performance, their judgment, et cetera. Unfortunately, the treatment for these conditions is not consistently effective. These are somewhat refractory to treatment. I've seen in 28 years working with ALPA, I think I've seen 2 or 3 exceptions to these getting certified, and it primarily was because the FAA didn't agree with the diagnosis and didn't think the diagnosis the individual had was truly one of these conditions. Let me talk about the HIMSS program, because substance abuse is prevalent. If you look at the various statistics, between 7% to 11% of people in the United States will have a problem with an alcohol use disorder, and a similar percentage with other substances too. The combined isn't quite that high because some people have both. But the HIMSS program is a long-standing program of safety. And the only reason the FAA spends over $1 million a year funding this to educate pilots and physicians and AMEs about this is because it's a safety program, okay? It's a cooperative program just like what we're talking about now with the FAA, the AME, the pilots, the unions, and medical professionals that are out there, particularly psychiatrists and psychologists who are trained in the FAA standards, Part 67 standards, as well as the disease itself. We do know that these conditions are associated with cognitive impairment, and even people who don't have a full substance use disorder by criteria of DSM-5 still may be impaired because of the effects, both the lingering effects or the persistent effects of alcohol or the substance of their choice. So therefore, the FAA requires people who are diagnosed with this and successfully in recovery to be absolutely abstinent for the rest of their certification career. And there's rigorous monitoring to make sure that that's in place. As a result of the success of the HIMSS program, the FAA has also designated HIMSS aviation medical examiners to follow pilots who have depression and are on medication, and we'll talk about that in a second. But these are the goals of HIMSS. We've had this, the HIMSS program went in place in 1972. The first pilot was certified in January of 1977 with this, but this has been the goal since the very beginning. And we look at this, this is where we are supporting the individual so they can safely return to fly. And these are the factors in our success of this. We've destigmatized the disease. You talk about pilots who are in the HIMSS program. I won't say they're proud that they're in the HIMSS program, but there's no shame, there's no guilt, there's no fear. And they're happy to talk with other pilots about it because we've destigmatized the disease. We recognize that this is a prevalent thing. Also, many of the airlines, United in particular, has provided tremendous financial support for pilots who are going through the treatment and recovery for this. United is famous in the HIMSS world for never firing a pilot who has had a positive test, who has entered into the HIMSS program, has had multiple relapses. United has consistently supported the pilots throughout this whole episode and all of the struggles that they face. And that's what they need, is they need someone to know that everyone is supporting them, including their employer. So there's tremendous communications between all of the people. We don't have secrets here. We communicate freely, And everyone is there to assist the pilot, because assisting the pilot saves a life, potentially saves a career, and enhances safety consistently. I've already mentioned the FAA continues to fund this. They put substantial resources because they consider this a good safety program. This is our research here from the HIMSS database. You look at pilots who have had the diagnosis of substance abuse or dependence. 86% of them do not have another relapse for the rest of their flying career. 11, almost 12%, have a single relapse and a return to flying. We do have a number of pilots who have had multiple relapses, but again, they're back flying. But if you look at the rest of the world that doesn't have the support, you can just flip those numbers around. About 10 to 15% of people are successful in not having a relapse. Right? But because of the support we give them, they are healthy and they are safe when they go out. So what are the numbers? These are numbers from 1 year ago, the most recent ones I have. We've had almost 12,000 pilots throughout the duration of the HIMSS program be certified and fly. And you can see right now we have over 1,800, that number is close to 2,000 right now, pilots who are on special issuance medical certificates first class for substance abuse, alcohol abuse, and substance dependence and alcohol dependence. So it's a substantial number. This disease, which is stigmatized by the rest of the community, is not within the flying world. Right? And you can go back and fly, just like if you had a heart attack, et cetera. Now, looking at another common mental health problem, depression. Depression, as I said earlier, affects mental illness affects a proportion of us, but about 20% of the U.S. population, slightly higher in females than it is in males, will have depression sometimes in their life. But the overwhelming number of these are relatively transient. But it can vary across a spectrum of severity, anywhere from the most severe with homicidal or suicidal ideations, and we'll see that with Andreas Lubitz, to mild emotional disruptions where people are mentally well, but not, let's talk about a situation where someone could not be happy, but be mentally well. Just to use an example of someone who's grieving the loss of a loved one, a child or a parent. They're filled with sadness and they may have a depressed mood. But because of their mental wellness, their resiliency, the strength that they have to bring that back, the support that they have, they really can handle that very well. Okay? Likewise, you may have someone with a terrible mental illness who is perfectly happy. Any examples from out here? We just talked about substance abuse. What about the euphoria that someone gets when they have those 4 or 5 drinks, or they're shooting up with heroin, the pilots there, and they have euphoria? They're perfectly happy, but they're not mentally well. They have an illness. We know also with depression, there are intrinsic and extrinsic factors. Some are genetic. There is a predisposition in people who have that, but there are a lot of extrinsic provocateurs as well. There's situations that we talked about that arise socially and personally. But there are medical conditions, such as pregnancy. We know there's postpartum depression is relatively common. Some of the medications that people take may contribute to a depressed mood, and some medical conditions they have. As I alluded to earlier, some of the chronic medical conditions can do that. And depression can coexist with other conditions. Substance abuse is very common, but there are 2 separate conditions, and also with PTSD, anxiety, or other conditions. The suicide rate in the U.S. In 2020 was about 1 in 7,000. So we had about 48,000. We lost over 100,000 to drug overdoses, though, too. But what was really shocking to me was the adults, and this is 18 and older, adults with serious thoughts of suicidal ideation. And it was between 1 in 20 and 1 in 25 in the U.S. So it's a substantial problem. And as I said earlier, just because we have a pilot certificate, because we have a medical certificate, doesn't give us any exemption from these conditions at all. So what are the FAA concerns about the host of Medical conditions, in particular depression. Well, depression is associated with fatigue. You have disturbed sleep, early morning awakening, delayed sleep, just fatigue. The cognitive impairment that comes along with that, we routinely see that in the HIMSS program, but it's also associated with depression. The faulty judgment that goes along with people who are depressed because they're getting desperate to do something. They may not have the resiliency or the mental wellness. Suicidal ideation is clearly a risk, but it's clearly a concern, but it's a relatively infinitesimally small risk. But depression can also be recurrent, and the FAA has a specific policy for recurrent depression and how that's managed. The medications can have some potential side effects that might compromise safety, and there are a variety of comorbidities, other diseases that go along with depression. So as Administrator Dixon talked about at the beginning, there, Andreas Lubitz and the German wings, 9525 in March of 2015 triggered a lot. We had the FAA Rulemaking Committee. EASA had a wonderful study as well. So unfortunately, when Andreas Lubitz murdered 149 people and committed suicide, it was a terrible tragedy, but some good came out of that. I think a lot of good has come out of that. And I hope with John Hauser's death that we move even further along that spectrum, that this good will reach down into the university aviation community and our young pilots as well. So as I mentioned earlier, I was on the pilot fitness arc of this, and I also wanted to contrast that with what the European Aviation Safety Agency did. We looked at different recommendations, and the ones in green are the ones that the FAA adopted. Enhanced AME training. Dr. Joe Benetti will mention this as well, I'm sure, but I believe 3 hours of mental health training has been added to the initial and recurrent AME training. Unlike the Europeans, we said that no psychologic testing on a routine basis for pilots was the status quo, and we would like to keep that because we didn't think that that added any value or would detect anything, because as soon as you have a standard questionnaire, every pilot's going to know how to answer it so that they don't get flagged in some way. They're not squawking ident to FAA medical here. We mentioned the idea that pilot assistance programs have been proven to work. Delta has had a long program, American Airlines with Project Wingman, and certainly the HIMSS program are long-term evidence that peer support programs work well. We felt that there should be an air carrier education element, and indeed that's happening right now. And informational materials should be there. We're having these summits, we're having a plethora of evolution of peer support networks. ALPA has extended it to all 38 carriers. The FAA and the EASA differed on the medical reporting requirements. In Europe, there are very strict privacy rules, and they were looking at making it mandatory that anyone who visits a healthcare professional, mental health professional, have that reported to EASA. The FAA hasn't agreed with that. But one area where the Europeans are way ahead of us is EASA mandated that every carrier in Europe have a peer support program, and it'd be funded by the airline itself. Okay, and that it was supposed to be in effect in February of 2020, but it went into effect in February this year. And they're struggling with doing that, and they're struggling with starting with testing. So let me talk about the spectrum of treatment for depression. Counseling, and there's a host of different types of counseling, but because we're left side of the brain type of people as pilots, we respond particularly well to cognitive behavioral therapy. It's essentially doing your homework and getting a checklist and following it, and give us a checklist, hey, we're golden, we know what to do, okay? It's very successful. There are various medications that are out there right now, but currently the only one allowed by the FAA are 4 selective serotonin release inhibitors. Canada allows some SNRIs and SMRIs as well, but no one, and Australia also has allowed these for quite some time. But no of the antipsychotics are allowed for medical certification, and certainly the non-traditional treatments such as ketamine, which is an anesthetic, and substance abuse and some of the hallucinogens. Also, pilots who have undergone electroconvulsive shock therapy or transcranial magnetic stimulation. It implies a degree of severity such that it's probably not compatible with safety and potentially recurrent too. So let's talk briefly about counseling. The evidence is that it's just as effective as medication in the long term. In the short term, the combination of medication plus some sort of counseling therapy is more effective. There's a synergistic effect, but long term, the counseling is good. It takes a little longer to get the improvement if you started counseling, but for pilots, it might be more costly because it's easy to go to a primary care doctor and get a prescription for Prozac and be out the door, and then you fill your prescription, and your total cost, out-of-pocket costs are $50. Okay, counseling costs more, it takes longer, and scheduling, particularly for a pilot who has a transoceanic type schedule, getting those visits, you can't be there every Wednesday at 2 o'clock in the afternoon. Okay, so that's a challenge, but it has wonderful long-term results. And most of this is done by mid-level mental health professionals, licensed professional counselors, et cetera, not at the doctoral level. But there are some challenges. I've already talked about the pilot schedule and the location. Releasing information to the FAA, that goes two ways. One, a counselor finds out that an individual is a pilot and they say, "But I don't want to see you," okay, too much risk. The other one is that when we do, because we actively encourage pilots to get counseling, when we ask for a note from the counselor so the FAA can determine that this individual is still safe to fly, we get this cheap little mother may I note. I saw Johnny for his depression, I treated him, he's better, let him go fly. That doesn't cut it at all. We need all the details, but it's against the code of ethics for many of the mental health professionals to go into the details of that individual's situation and how they were treated. But that's counterproductive when you're looking at it from a regulatory perspective and trying to get the person certified. And then there's also the insurance coverage, which I'll talk about in just a second. Next slide, I guess. These are the medications that are allowed by the FAA. I put down there in the bottom that Wellbutrin may be considered in the future. Dr. Giovanetti can talk about this. It was considered in the past, and then it got a black box warning that it was dangerous and might cause increased risk of suicide in children. That black box warning was removed about 3 years ago, but still, Wellbutrin as an anti-anxiety drug is currently not approved. It's also used as an anti-smoking drug. But these are the conditions right out of the guide from aviation medical examiners that are allowed to fly while on SSRIs. And these are the conditions that are not eligible. We've already mentioned psychosis. Suicidal ideation, a history of that. That's somewhat nuanced because it can vary anywhere from vague thoughts. As I said, 4.34% of the adult U.S. population has had serious suicidal thoughts in the last year, to going all the way through a specific idea, formulated plan, or a non-completed attempt. I've already mentioned if you've had ECT, you're not eligible, or if you're using multiple SSRIs or multiple medications, you're not eligible for certification. This is not for anyone to memorize or look at, but this is straight from the Guide to Aviation Medical Examiners. And it basically says this is the route to be certified if you have depression and you're treated on one of the allowed medications, okay? And if you're on one of the allowed medications and you go to decision path 2, and it talks about all the things, but as you can see, what I've already spoken about in the red boxes, that's not allowed, but there's a lot of ways to get to yes, as Administrator Dixon said. Okay, the FAA is looking to get to yes on this. More recently, particularly with a lot of our veterans returning from the Mideast and Afghanistan, PTSD has risen to the forefront, but these are the diagnostic criteria for PTSD. Right? Many people who have been labeled with PTSD don't really meet the diagnostic criteria. It's kind of like ADD of the 2000s, you know, it's the diagnosis du jour right now. But a lot of people may have trauma in their life, but they don't have PTSD. When I did my first mishap investigation, I had pretty much all of these symptoms, but it didn't last for 2 months because I went and got therapy for it, and that took care of it. And so I was on the road to this, but because I was fortunate enough for the Air Force to help me and intervene early. That is not a problem with me right now. You hear that, Penny? I can still keep my medical certificate. And this is out of the Guide to Aviation Medical Examiners about if someone has a diagnosis of PTSD. The AME can issue if the individual meets all of these criteria. There are a lot of other psychiatric conditions that people have, mental health conditions, I should say more properly. In general, if you're using medications for them other than the 4 SSRIs, those medications are disqualifying. But the FAA encourages, and all mental health professionals encourage getting counseling. It's very, very effective. That counseling may be reportable, but not disqualifying if we have that comprehensive report, not the mother may I note, from the counselor. And it talks about this, the onset of symptoms, how it was treated, the absence of medications in the treatment, their current status, their prognosis, and you can continue in treatment and still continue to fly. The FAA will follow until it's resolved, and usually for at least 1 year after it's resolved, to document that it's not recurrent. And there are lots of minor psychiatric conditions, bereavement, dysthymic disorder, that's kind of feeling down a little bit, mild depression. But again, the AME, this is right out of the AME guide. The AME can issue if these conditions are met. Right? So again, we're looking at problems of degree. All of us are going to face these things that I have here. You look at this and there's no one who's exempt from it. But the bottom line here is that peer support is particularly effective. And that's what these programs are about. And that's why we'd like to bring it down to the university level as well, to make sure that we have peer support for those people who are struggling with exactly the same problems that all of us have, but because of the age cohort that the university students are in, they're at increased risk. So what is reportable to the FAA? If you look at MedExpress and question 19, it has the explanation, lists all visits to healthcare providers in the last 3 years. With the exception of marital or family counseling, as long as you don't have a personal diagnosis of substance abuse. So peers are not healthcare providers. That, an encounter with a peer is not a reportable event. Right? Likewise, EAP visits are not reportable as well. So this is the direct language from the drop-down menu in MedExpress under question 19. And it said the applicant should list visits for counseling only if related to a personal substance abuse or psychiatric condition. That's a little bit nuanced because the psychiatric condition, again, you continue and it talks about the same thing. We go back to the insurance issue for the providers. For them to get reimbursed, they have to list some sort of condition in DSM-5, okay? Now, DSM-5 doesn't correlate with the FARs on that, but in our office, we always encourage pilots to report that, but to do that reporting with a comprehensive note from the counselor and to make sure that, that they're well before they fly. And I'll conclude with some information about that. So what are some of the other barriers to seeking help? Well, we're our own worst enemies. We're obsessive compulsive, we're independent, we're narcissistic, we're confident, and we're problem solvers. So if a mental health problem arises, I got this. I can take care of it. I don't need anyone else's help, okay? That's the wrong answer. The thing that makes us good in the cockpit makes us lousy as asking for help and seeking help in mental health. So what are other barriers? One is the lack of aviation-savvy mental health providers. Most mental health providers don't have a clue as far as the FARs, about the relevance of aviation, what a pilot's life is like. I will say I think the Europeans are far ahead of us in this area. They have an association of psychologists who concentrate specifically on aviation. There are over 200 in this membership in this organization. And they have the Center for Aviation Psychology headed by Dr. Robert Bohr and Adrian Becker. They have a lot of good publications and specifically looking at mental health. So I would recommend their materials as well. And hopefully sometime in the United States we get to a parallel position. So what are the values of aviation-savvy mental health providers? Well, we have the diagnostic brinksmanship, as I like to call it, among the non-aviation mental health providers. where if they are willing to see a pilot, which many aren't, they may elevate the severity of the diagnosis so they get better reimbursement for that. Okay? So that's a potential problem when you're going for certification without that comprehensive note. They are reluctant to provide full records to the FAA because they want to protect the individual's privacy. But the FAA has a concern about the safety of the national airspace system, and they need to review that information to make sure the individual is indeed safe. And certainly, aviation, most non-aviation savvy people are not familiar with the FARs. Looking at, there are all kinds of initials after people's names at the mid-level master's health counseling. That's where the majority of counseling is done, and that's really where it's effective and convenient. If you have a psychologist, usually a PsyD or a PhD, they are trained in a little more intense counseling, a lot more intense counseling, can do that, but they can't prescribe medicines. Only a physician. We talk about psychiatrists, but most of the prescriptions are actually written by primary care physicians who may or may not have the time to augment that with counseling. What I really like is when a pilot has a good primary care physician who is willing to prescribe medication simultaneously with someone getting counseling, or intermittent referral to a psychiatrist to assist with that. So another barrier to pilots seeking help is the lack of peer support programs. The good part about Andreas Lubitz, and hopefully a benefit that will come from John's tragic demise, is that we will have peer support programs. And we've seen a proliferation of peer support programs across the world. We're being asked to present this information. I want to give a shout out to New Zealand PAN, which is that green one there. New Zealand, they're a country of 6 million people, so this is a little easier to pull off. But they include in their peer support all of their pilots who fly professionally, all of their flight attendants, their air traffic controllers, their maintainers, the people who own FBOs, ab initio students, CFIs. Everyone is included as a peer in that environment. And that's the only one I know of that encompasses everyone in the aviation career. So they've gone a long way. We look at the ALPA peer support program. We have Carrie over there running that program. There are a lot of different models of peer support, but any peer support is better than the status quo, particularly 5 or 6 years ago. So what are the mental health concerns? And this is just, this is a 2-minute search on Google about the public's concern about pilots. And we see that one about researchers say industry practice should change to encourage workers to seek help when they need it. That was just in June. I will say that the British Airline Pilots Association Peer Support Network, when BA went down and wasn't flying at all, they used their BALPA pilots, the British Airline Pilots Association, peer support pilots, to go to the National Health Service and provide support for their providers, their nurses and clinicians. And they actually went out there, and then they got a letter from the Prime Minister saying what a great job they did, which is really nice. Joan Cahill down at the bottom, she's done surveys on the need for pilot health and the desire. Over 40% of pilots that responded to her survey indicated they needed mental health help, but only, I believe it was 4% sought help. It was a very small percentage, and she's working with us in the Aerospace Medical Association's efforts for that. So we talked about mental health, but let's talk about some of the other problems. We talked about peer support. We have the Critical Incident Response Program, which is a little bit different, and that's a more proactive. It reaches out to an individual who has faced a trauma, usually a work-related trauma, but by having the ability to allow that individual to defuse, to talk about it, and then to debrief them about the resources, we can prevent a lot of tragedy. So just going through the history, this evolved out of Aloha Airlines 243, which was a 737 that had an explosive decompression, became a convertible in flight, and unfortunately one flight attendant was sucked out. You see Mimi Tompkins in the doorway there. She was the first officer on that, and she was the impetus for this program. Clearly the crew brought the plane back and everyone landed safely, and she was hailed as a hero. And she was, as well as the captain. They were both heroes in this situation. But 1 year to the day after this event, she was talking about this in Sweden and gave a talk about this event. and tried to go up air stairs. They didn't have a bridge at that time. Tried to go up an air stairs to a 737 and couldn't get on the plane. She broke down completely, called our office, and that was the nidus. And so she was the first person as a pilot critical incident response program. And where it paid dividends was the Reno air races back in 2011 when Galloping Ghost went down. Okay. There were a number of people in the crowd who were injured and killed. We had over 50 ALPA pilots involved there, and ALPA proactively sent out, I believe it was over 50 critical incident response volunteers to do that diffusion and debriefing for these folks, and it prevented a lot of illness, but it also allowed people to take that time off because we had the critical incident response program in place for that. We have other peer support programs, professional standards, and that's when people aren't playing well together in the sandbox or the cockpit, and we try to get those issues resolved, but again, among peers. And the pro stance individuals frequently will find issues that may get referred to other folks, such as the HIMSS or peer support. So a wonderful thing, if this is an outward manifestation of potential problems, but what is the underlying cause? And that's where the pro stance folks are so well, do so well, and that's why they're cross-trained. The peer pilot support programs, we have multiple representatives, so I'm speaking to the choir, so to speak. In the US and the UK, they're generally union run. They're mandated to be run by the company, and Europe right now. But unlike critical incident response, pro stance, these may be long-term relationships. You may be talking with an individual for 2 or 3 days, or you may be talking with them for 2 or 3 months, or possibly 2 or 3 years, because you develop a collegial relationship with them. But these peers really are designed to listen to an individual, not solve their problems, but to provide them with the resources that are out there to assist them with where they need that. And occasionally that results in a mental health professional referral. Also, right at the very end, I'll talk about the decision-making about a fly, no-fly decision too, because a peer is not able to make that decision for the individual. The individual needs to make that, but we can certainly provide assistance to help get them to the right answer. And we'll talk about that in just a second. So this was published on the ICAO website, written by Indian physician Punita Masrani. And she talks about the dirty dozen of flying, and this is the concluding paragraph from about a 12-page paper. But what I wanted to point out, that this is an interdependent relationship of psychological, biological, social, and spiritual things. And that's what mental wellness is about, is working on all of these things simultaneously so that you build that strength, you build that resiliency, you have that reserve to handle those problems that come up with that. But it's a holistic approach that goes for this to maintain our mental well-being. So, I know we got 120 people from UND looking, so I asked this question semi-rhetorically, but how many of you use a checklist with your aircraft before you take off to fly? Okay. I say a few hands go up here, so the rest I'm assuming are mental health professionals aren't flying. Okay. So you use a checklist all the time to fly your airplane. But an airplane usually has a dichotomous type thing. Either you get a red light or a green light, or it's working or it's not working, and it's easy to tell. But the most likely element of this safety chain to fail is the human. And what's dangerous is the human doesn't fail in a dichotomous way, usually. Right? You fail in subtle ways. You're subtly compromised. And we're our own worst judges of our ability to do that. So when people call our office, we ask them to run an I'm safe checklist. Do I have an illness that could affect me to fly? Am I taking any medications? What's my stress level? What's my alcohol consumption? You know, there's the 8-hour rule or 12-hour flying for certain companies, and the 0.04 level. But even if you're following all of those rules, you may have some persistent effects from alcohol or other substances. Fatigue, there are lots of fatigue risk management programs out there. And it's definitely an issue that compromises safety. And if you look in the AIM 8-1-1, it talks about emotions, but all the pilot operating handbooks that the FAA has published since then talk about, more appropriately, I think, eating and hydration, because emotions falls into stress. So I asked the pilot, would you put your family on a plane with a pilot in your situation if it was a single pilot operation, allow them to fly? And if they can't answer definitively yes, say, you probably shouldn't be flying. And Part 6153 of the FAR say that you have a responsibility not to act as a required crew member or perform those duties if you have a medical condition or taking medication that could impair your ability. So let me just, so I appeal to the person's safety, and I appeal to their professionalism. But for the students that are out there, you don't have to be a paid pilot to be a professional. And let me give you an example. I've been a flight instructor for 47 years now. I have the privilege of teaching a lot of young people. I fly gliders primarily, so we start teaching folks at 12, 13. We solo them at 14. I had a young man who started flying with me at 13, soloed on his 14th birthday, got his private pilot certificate on his 16th birthday. His social studies teacher was the one who encouraged him. His family was very supportive, but his social studies teacher encouraged him. So as his first ride as a private pilot, he wanted to take his social studies teacher up. He couldn't drive. He didn't have a driver's license, but he had a pilot certificate. So she drove him an hour out to the airfield. And he asked me to sit in, and he did he went through the I'm Safe checklist and gave a great passenger briefing. We dragged the sailplane out to the end of the runway, because you got to push them since they don't have engines. And we took it out to the end of the runway, and he asked me to hook him up. Tow plane's in position. He hooks up the plane, and they're starting to take the slack out of the rope, and he opens the cockpit. And I said, JT, what's wrong? And he said, I'm feeling too stressed to do this. I can't think that I would do this safely. I don't think I should fly. And to me, that was the epitome of professionalism in a young kid who wasn't getting paid. Okay? To his credit and to his teacher's credit, they came back the next week and he was much better and he flew. And he sent me an email this summer as he was involved in, this was like 15 years ago that this event happened, that he was involved as a C-17 aircraft commander in the medical evacuation in Afghanistan of some wounded folks, and it had a similar, I won't say a similar situation, but he had another situation come up where he talked about, I went through this I'm Safe checklist. I remembered what we talked about at the beginning. That helped me make the decision about whether this, and it was a very dramatic issue with life-threatening illnesses, et cetera, bad aircraft, et cetera, about whether I should fly this flight or not. And again, he continues to be a professional with that. So kind of the bottom line for this is these conditions are common. If you ask for help early, you'll do better. I like to draw the parallel between when we're flying and we're in a spiral dive or the graveyard spiral, and we can do the same thing psychologically. And if things start to go bad and we stress and we don't have that mental wellness, what we need to do psychologically is release some backstick pressure, roll our wings level, and climb slowly to regain that psychologic altitude so we can safely continue to fly from there. Right? Consult people who are trusted in this area so that you get the help that you need when you need it early so it's most effective. So just to summarize, again, mental health problems are common. Most are compatible with flying. Again, we all have stresses. In most cases, we can compartmentalize. We're real good at that, and we can compartmentalize and fly safely. But health and safety is the most important. Okay? Taking that flight is not the most important thing in the world. Health and safety is. JT was close to the most important thing in the world was on that flight out of Afghanistan in the C-17, but in most cases, health and safety are the most important. Most mental conditions, particularly if we work on our mental wellness, and we work on that each day, don't need treatment. They may need someone to talk with And that's where the role of peer supports come in. If you ask for help early, you will be back in a psychologically healthy mental wellness state early, before you've lost too much psychologic altitude. Early intervention really helps. And if you're honest with yourself and you look at whether you're safe to fly using the I'm Safe checklist, you use it on your aircraft, use it on the element that's most likely to fail, then you'll be in a good situation to continue to fly and to fly safely.